More time. Welcome to fully integrating lactation support into the patient visit. This is our March portion of our First Food Equity series. I'm inviting you all to sign in, and we're just going to watch a little video. I'm sure many of you have seen it before, but it is my favorite vision of what it looks like when we all work together.
Is there a place where everyone, regardless of race, economic background, or gender, grows up with the opportunity for good health, a good education, and a good job? This place is not in our heads, but in our hands. It starts with a mother and a baby. Actually, it can start with all of us. It can start with you. When you support a woman's health long before she chooses to have a baby, and when she gets pregnant, you help her receive excellent prenatal care close to her home, where you explain why breastfeeding matters in a manner and language she understands. Before she gives birth, in a baby-friendly hospital you helped establish, where you help her breastfeed her baby right away, allowing her to bond with her baby, who breastfeeds well, and you're always there to help. When this mom and baby go home, you help them some more, and her friends and family do too. And she breastfeeds her baby for at least 6 months, and gets to stay home and care for her baby. And her partner gets time too, because they have paid family leave, thanks to your efforts that made it the law. And when she returns to work, her boss encourages her to take breaks, to pump in a clean space required by the law you helped pass. And there's childcare right there, where people understand why breastfeeding matters, because you led the way. On the weekends, her family shops at a local green market you helped set up, where they buy good food that is local, healthy, and affordable, that helps her child run, play, learn, and grow up in a safe community with clean air and good water, until one day, many years from now, she gets her own job with good parental leave, and has her own child, and breastfeeds her. It takes every one of us to create a culture where breastfeeding is the norm, and help a community become healthy right from the start. Beginning with one mother and one baby, we can help achieve health equity everywhere. Each and every one of us can make it possible.
I love that video. We at Breastfeed Durham do not receive any funding from the WK Kellogg Foundation, but I love that video. It was one of the first, just as Breastfeed Durham was beginning this work, and I was starting to type into Google about our work and the 10 steps to a breastfeeding family-friendly community created by the World Health Organization, WABA, and the Carolina Global Breastfeeding Institute. It was first piloted in Chapel Hill, Carborough, and Durham became the second pilot project almost 5 years ago. And I was approached by an IBCLC in the community, Gina Rose, and she approached me as a little H League leader at that time and said, "Hey, love, have you seen these 10 steps and are you interested?" And as we were exploring whether or not this was something we wanted to do, we came across that video, and I remember distinctly it's actually one of my kids who found it on YouTube, because they always help me, and they were little but amazing with computers. And my little guy, I think maybe Ethan was 6, came toddling over and was like, his solution to everything is a YouTube video. He's like, "Mommy, have you seen this?" And I watched it and I started crying. And it really came back to my mind today as we were asked by some IBCLCs working at Duke when we started this First Food Equity series, what kind of conversations did they want to have? And I wanted to take a moment today to have just an honest moment where we talk about that our goal at this series is to really talk about first food race equity and racial inequalities. And I want to lean in and say, we have a white presenter today who was invited upon request. This is a conversation that a lot of our doctors and our pediatricians wanted to have, where they're like, well, what they said to us, like, what does equitable partnership look like? And I immediately thought about Emily. As we think about first food race equity and partnership, I think about how the very first time I met her was as a mom attending a North Carolina Breastfeeding Coalition meeting. And I just showed up, and she was sitting there, and she said that she'd gotten a new job locally, but it didn't start for a few days. And she had just shown up to come and do this work and to be part of the North Carolina Breastfeeding Coalition meeting as a volunteer, unpaid. She wasn't getting paid. She was new to the community, and she showed up as her whole self, as a parent, as a doctor, as a community advocate. And that's what we think about. That's what I think about. That's what our organization thinks about when we look at authentic partnership. And I want to welcome, I see a few more people coming in. Please sign in the chat. I'm going to put that up there again. So one of the other things that we wanted to talk about is partnering with providers. What does that look like? We believe by leaning into this racial equity lens that we can build bridges across divisions, and we can work together to create authentic relationships. We know that one of the things that we're all working on is our implicit bias and doing these equity trainings. I think that one of the pieces of feedback as we've done this series, and we have had you guys do your surveys to figure out, what we're doing right and what we're doing wrong. One of the pieces of criticism that is really real is, as we've gone through this series, we've heard some negative things about pediatricians. And I think that one of the things we wanted to have a conversation about is we want to celebrate each and every single one of you who showed up to here today. Those of you who may be watching us one day on YouTube following this, is that those of you who are leaning in to do this work, I mean, I think it's real that oftentimes you're not the problem, right? It's how do we reach those other healthcare providers who are not at the emotional place where they're ready to do the work. And we believe that each of you are the key, that with partnership that we can always reach one, teach one, that we can reach beyond ourselves to create solutions to change the world. And I'm really thinking about this as we approach the 5th birthday of Breastfeed Durham. 5 years ago, a little less, it'll be 5 years in May, there were really very few lactation support resources within the borders of Durham County. Duke was just at the very beginning of working towards their baby-friendly hospital initiative. They were just starting to do this work. And as we move forward and we advocated for this change, we're really excited to hear that Duke Regional is really close to completing the award. I used to see IBCLC showing up at health events doing fairy hair to supplement their income. And that was one of the things that made us feel really angry. We wanted the IBCLC credential to be recognized. We wanted our IBCLCs in our community to be funded. And we truly believe that by creating this partnership, we could change the community, y'all. And I feel like we're getting there. We're not done yet. We're still at the forefront of our journey. But we believe that all healthcare providers play a critical role in success. But really, today we're leaning in and talking about partnering with not just all healthcare providers, but particularly pediatricians. We know that you are often the first contacts for our little bitties, and that by working together, we really create success. We depend on you as parents. We depend on you as community advocates. We depend on our pediatricians, and we really want to celebrate. We want to celebrate our pediatricians. We want to celebrate all of our community advocates and our healthcare providers for supporting our community. We appreciate all of you so very much. And we're really looking forward to hearing more about what Emily has to say and what she's thinking. I put her whole bio up here. I had to put in 2 pages because what I loved about when I was reading her bio was, I'm gonna jump ahead, was the second page where she authentically talks about her children and her love of ice cream and how she's had this lived experience of living in California and having moved to a very small town in the Northeast. And then she's gone all over the country and seen a lot of different ways that people live and grow and been able to be trained in supporting healthcare in all of these environments. And she just, what I think changes our community is bringing your whole self to this work. So we'd really like to warmly welcome Dr. Emily Hannon to do our presentation. And I'm going to start presenting and let her turn on her slides. So thank you.
Thank you, Love, so much for that really, really wonderful introduction. I might hit you up for future introductions. That was great. So while I'm doing this talk, I won't be able to monitor the chat. So Love, I'll rely on you and your teammates to help me, let me, feel free to interrupt at any time if there are any questions. And so, as Love mentioned, I am a pediatrician. I'm also a lactation consultant. I've been involved here in North Carolina for the past 5 years since I moved here with my family from California, where I was involved as a pediatrician and lactation consultant for 10 years. And so I have worked in a number of different settings. In California, I worked at Kaiser Permanente, which is a huge organization that holds, most of the healthcare share in California, and was a proud member of that group, which I think is doing really amazing work in the breastfeeding world in California and in the Northwest. And then moved here to North Carolina and accepted a job at Duke as the medical director of the newborn nursery. And I enjoyed that role. That taught me so much, and I met so many people for about 1.5 years. But then I actually really missed seeing older kids in the newborn nursery. I only saw babies until they were maybe 3 days old, and then they went home and I never ever saw them again. And I missed that continuity of care. So I joined my current practice at Western Wake Pediatrics about 2.5 years ago, almost 3 years ago. And funny story, tomorrow, 3 years ago, was supposed to be my first day at work. And if any of you remember what was happening exactly 3 years ago today, the world was shutting down due to COVID. And so my first day at work got postponed by a few months. But I'm so happy to be here at Western Wake Pediatrics. And I'm going to spend today talking about some of the work that I have done both here and at my prior practices about how to integrate lactation support, but really focusing on the best practices for medical office settings. So we're going to take a step away from the hospital setting. Typically we talk about the 10 steps toward baby-friendly hospital status, but really today we're going to talk about continuing that work in the outpatient setting after the baby goes home at 2 or 3 days. How do you continue that work? So a couple of the objectives I have for today is that by the end of the session, I hope that you'll be able to identify a couple steps suggested by the American Academy of Pediatrics, the Academy of Breastfeeding Medicine, and the Academy or the Association of Colleges of Obstetricians and Gynecologists for creating a breastfeeding friendly office practice. And then we're going to discuss some ways in which lactation professionals, no matter what your level of lactation training, how you can add to the services provided for these families. We're going to spend a little bit of time talking about billing tips for lactation services. We'll talk about some collaborative ideas with the community. And then I'm going to end with telling you about some awards that you might be eligible for through the North Carolina Breastfeeding Coalition. So we'll start by talking about the American Academy of Pediatrics and their clinical report, which was published in 2017, about how to make pediatric offices breastfeeding friendly. So these are the 14 steps that they have identified as supportive breastfeeding friendly practices. And I've highlighted a few of them because these are the ones that we're going to go into depth with today. You may know that the American Academy of Pediatrics recently increased their length of suggested breastfeeding from, it used to say exclusive breastfeeding for 6 months with the addition of complementary foods until 12 months. So breastfeeding until 12 months or as long as mutually desired by the patient and the parent. But now they really increased that because so much evidence is backing up prolonged breastfeeding, so breastfeeding till 2 years or longer. And so the wording has been changed slightly on that. As we all know, the long-term benefits of breastfeeding are so extensive. And so the American Academy of Pediatrics has reflected that in their current statement that was published a few months ago. So in addition to the American Academy of Pediatrics, there are suggestions for supporting a breastfeeding friendly office practice. The American College of Obstetricians and Gynecologists has also published a committee opinion about the support of breastfeeding as part of obstetric practice. And because most obstetricians focus their care on babies in the hospital, this opinion statement really focuses on the 10 steps and hospital care, but paying special attention to the fact that we all know that moms and families decide how they're going to feed their baby long before the baby arrives. And that takes place in the obstetric office when they're going for their every 6-week checks. And so I really encourage my OB colleagues to talk often and early about breastfeeding. Every time you see a patient in the office, to say, okay, so how are you feeling about breastfeeding now? What have you heard since we last talked to each other? What myths can I dispel for you, and what support can we provide for you before this baby arrives so that you can get off to the best start for both of you? And then the Academy of Breastfeeding Medicine has also published a statement about how to support breastfeeding in the physician office. This was published in 2021, and some of their key points that are similar to the AAP points, but providing culturally inclusive care, not accepting formula incentives from formula companies, and teaching about formula preparation, and then having some breastfeeding friendly office spaces, and finally normalizing breastfeeding. And so we're going to talk about all of these things in turn. And lastly, the Surgeon General in 2011, this is a little bit dated, but I think still important, set out a call to action to support breastfeeding. And in that statement listed a number of things, and these are the ones that are relevant to breastfeeding. The ones I've highlighted here that we're going to discuss is the continuity of skilled supportive lactation after they leave the hospital, and ensuring access to IBCLCs. Okay, so the first part we're going to talk about is incorporating breastfeeding observation into routine care in the outpatient setting. So after the babies have left the hospital, where they're getting constant intervention and constant help with breastfeeding. And then I feel like it's almost like that scene from The Princess Bride, where the people are waving at the castle and they say, have fun storming the castle, like, bye-bye. That's what I feel like we do when babies leave the hospital. We say, okay, we've helped you with breastfeeding every minute of every day for the past 2 days, but now you're going home, bye-bye, see you later, good luck. So we need to be able to help them in the in the outpatient setting after they leave the hospital. So when I'm talking to providers, particularly pediatricians and obstetricians, about breastfeeding, I go back to the basics. Because when I went through medical school, I learned nothing, literally nothing about breastfeeding. And even in my pediatric residency, I had to request a special rotation with the lactation consultant because I wanted to learn more about it. And even then, I didn't really get a good handle on it. I had, a couple days in my nursery rotation of working with a lactation consultant. So this is not a part of routine pediatric training, although I will say there's been a lot of work done in the past decade to help improve that. But when I'm talking to providers about breastfeeding, I really focus on the core things, talking about these positionings. The top 4 are usually the ones we focus on most, just because they're what they're used to seeing. And if I can get pediatricians familiar with walking into a room with a breastfeeding parent and not sort of shying away and being like, oh no, I'll come back later. No, to come in and say, it's okay that you keep breastfeeding. Let's see how it's going. Can I check out the latch? Like, being able to really get in there and help the family makes the family feel more comfortable too. I talk about good latch. I mean, you guys have all seen these images of just like, what are the things you look for? I feel like if I can give an unknowledgeable pediatrician a little bit of information about breastfeeding so that they feel comfortable with providing that level of care for their patients, that's going to really help. I don't expect to be able to train all pediatricians to be lactation consultants or IBCLCs, but I do hope that all of them will feel comfortable with breastfeeding and have a little bit of information that they'll be able to help their families. And I really rely heavily on this global health media. I know you all know these videos. These are fantastic videos. And if I just show a short little segment during one of my talks about what it looks like to have a baby breastfeeding well, it's going to really help to improve my colleagues' knowledge and really comfort with breastfeeding, and both observing their patients with breastfeeding, but also maybe making a little tips to help. The next part is about in your office, encouraging breastfeeding in the waiting room, but also providing a private space on a request, and then providing breastfeeding friendly spaces. So I have a couple examples here that we're going to review. First of all is this sign from the Virginia Department of Health. I love this sign because it's in a couple different languages, and it just says breastfeeding is welcome here. So something as simple as a sign in the waiting room saying you're welcome to breastfeed your baby anywhere. In my office, I always tell new parents when they come for our prenatal visits, you're welcome to feed anywhere in our office where you feel comfortable. But if you'd like a private space, we also have that available. This is the private space that we have in my office. It's a converted closet, honestly. Like, it's just a little room, but our lactation consultant, Bonnie Reed, has really worked hard to make this a little space that's really nice to use for families. And when this space is not available, we always encourage families to, like I said, breastfeed in the waiting room, or if they're already in exam room, give them a little extra time in the exam room to be able to feed their baby there if they need a private space. So there's lots of options of what you can do in your office. The AAP and the ABM and the Surgeon General's talk all talked about providing culturally inclusive and ethnically competent care. I know Breastfeed Durham is really interested in that. And so I just want to show, these are a couple images. They're a little grainy because they're taken directly from the Academy of Breastfeeding Medicine paper on making a breastfeeding friendly office space. But I love that this is culturally inclusive. Here's another one that has a cute little baby on it that tells all the benefits of breastfeeding. And this one also in Spanish, and why it's so important for babies to breastfeed. So these are just a couple examples of things that you can do, but it really doesn't all come down to posters. I don't want us to rely just on print materials, because I really would like for our providers to be knowledgeable about the differences of breastfeeding in different parts of the world. And so this is an excellent article. If you haven't come across this, I would encourage you to take a look at it. This talks about the cultural issues surrounding breastfeeding in lots of different places around the world. It's a little bit dated also, 2012, but not much has changed. So here are some cultural variations from this article and from a couple other sources that I found. So in Korea and Thailand, if a provider or somebody says a baby is beautiful, there's a feeling that it will curse them. And so I'm also always very careful about not using the word beautiful, actually with any baby, because I don't want to slip up if I get the culture wrong. So I always say that the baby looks very healthy instead of very beautiful. In Muslim countries, they often rub a softened date on the baby's palate before the first feed, which is very different from what we do here in the US. In over 50 countries across the world, one study showed that parents will withhold breastfeeding for the first 48 hours due to a belief that the colostrum is dirty or old milk. And so how do you, knowing that 50 countries throughout the world think that colostrum is not liquid gold, how do you then in your work help those families? Interestingly, the same study that identified 50 countries where parents believe that they should withhold breastfeeding for the first 48 hours, those same countries had a much higher exclusive breastfeeding rate at 3 months and 6 months than other countries. And so just withholding for the first 48 hours does not necessarily mean that they're not going to be successful with breastfeeding. However, from a medical standpoint, we always would worry about hypoglycemia and other things. And so you'd want to be careful about that and not just giving parents the ability to withhold breastfeeding. In Kenya, sometimes breastfeeding is avoided after quarrels to prevent bad blood entering the milk. In Mexico and other Central American countries, los dos is often preferred. I've often heard families tell me, well, I just want to give them the best of both options, the best of both worlds, formula and breastfeeding. And when I hear that in the nursery or early on in the breastfeeding journey, I will often say to parents that that's fine if you want to do both breastfeeding and formula, but in order to do both, we've got to really get breastfeeding well established. So let's spend our time in the hospital working on that. Like, let's do exclusive breastfeeding while you're here so that you have the ability to do both in the future. And that's actually resonated really well with some of the patients that I work with. And then this article ended with some interesting things about the US that we don't often think about. Parent-infant separation at birth, taking the baby to the nursery so the parent can rest, or especially during COVID, we had a huge rash of parent-infant separation. Early weaning, because it's socially unacceptable to be breastfeeding a baby past age 2. It's something Breastfeed Durham has been working very hard on. Focus on breastfeeding is taking away maternal control and independence. That has been an increasing issue I have seen in the US. In fact, this news article, not really a news article, but from Slate magazine, reflecting on the British Medical Journal's recent decision to ban formula ads. And this article saying, hey, wait a second, formula is the epitome of feminism, and you're taking away our right to choose. I feel like the formula companies are latching on to that feminist argument and really riding it. And so we as lactation professionals need to really be ready to push back on that and to encourage, from a medical standpoint, to encourage families to breastfeed for both the medical reasons for babies and moms. Talking about formula for a second, we're going to talk about the elimination of distribution of free formula in the office setting and not accepting incentives that can be perceived as promoting formula. So when I talk to pediatricians and obstetricians about not accepting free formula samples from formula reps, that's a really hard sell. And I'll tell you why it's a hard sell, because they've been so used to doing it. They've been so used to the formula companies coming in and providing lunch for their staff and giving free formula that then they can give to their patients if needed. But what happens is that when we give formula to our patients, if they don't medically need it, it tells the patient, oh, my doctor gave me this. That must mean that this is the best thing for my baby. So we really want to eliminate the distribution of free formula unless it is medically indicated. So I'm going to tell you a little story about how we did that in our office. Here's an example of how one of the formula companies will market to moms through pediatricians, right? So this is direct to patient marketing. Try it for free. Our breastfeeding support kit is perfect for moms who want to try supplementing. At your next doctor's visit, get your free sample. And so that's just really setting doctors up to be the free salespeople. We're providing this service, we're providing this formula for free. We are unpaid labor for these formula companies. And I think the more of us that stand up against that, the better off we'll all be. So in my office, when I first started here about 3 years ago, we did distribute free formula. We had formula wraps coming in frequently, bringing us Chick-fil-A lunch for our staff and providing us oodles and oodles of free formula to distribute. I wanted to change that. And so I worked with our lactation consultant, Bonnie Reed, to come up with a process for changing that. The first step that we did was to track our current formula distribution. So when we were still receiving formula samples from the companies, we created this spreadsheet that we hung on the back of the cabinet door that held our formula, so that every time a nurse or a provider went to get a free sample formula to give to their patient, they would record what they gave and how old the patient was and how much they gave. This all started when I was here in the office only a short period of time, and I came into the room to see a baby who I had seen before. It was a 6-month-old baby here for a well visit, had been doing breastfeeding with a little bit of formula supplementation for their entire 6 months, was doing really well with breastfeeding. Mom wasn't having any problems. And I walk into the exam room, and on the counter is an entire tray of formula. So like a crate of formula. And I looked at that and I looked at Mom and I said, oh, where did this come from? And she said, oh, well, your nurse brought it in. And I said, oh, are you having problems with breastfeeding? Do we need to help you with that? Because I know you've been breastfeeding and doing a little bit of supplement. And Mom said, oh, no, I'm not having any problems. Your nurse just brought it in and gave it to me. Wasn't that nice of her? And I went back to my nurse afterwards and I said, so what happened here? Like, why did you give her all this formula? And my nurse said, oh, well, I was going through our supply and it was about to expire pretty soon. So I thought she would like it. And of course, the mom did like it. Wasn't that nice of her? But what that did was set up for my patient to think that I was suggesting that the formula was better and that I was giving her free formula. And so that's what really turned it for me, is that I needed to figure out a way to tamp down on that. So after we started tracking our current formula distribution, We then required the provider order for formula distribution. It could be either a verbal order, so I could say to my nurse, hey, the baby in room 1, I've been working with them on feeding issues. They need some formula to go home. Can you please get me 1 bottle of the pre-mixed Enfamil, formula? And so then it was a specific amount. We were still keeping track of it, but just by requiring a provider order and not letting our nurses sort of distribute the formula willy-nilly, this cut our distribution by a lot. Then we did some financial calculations. Using those sheets of how much formula we were giving out, we calculated what it would look like if we, the practice, bought the formula ourselves. And we calculated it on a per patient cost. So there was one patient who got a couple cans of Alimentum from us, which added up to about a $90 service that we were providing to this patient because Alimentum is so expensive. So yes, that's really important for the patient if they're having a financial constraint, but there are other ways to get that formula. And so I thought that we needed to find better ways to provide our patients that service. So we strengthened our collaborative relationship with our local WIC agency. This was really key. We invited our local Wake County WIC office to come and present lunch and learns for both our staff and our providers, and we bought lunch. We did not have the formula company buy lunch, right? We stopped that so that we provided lunch for people. We made it easy for the providers and the staff to refer to WIC. One of the things I always tell my providers that I'm talking with is when we have families with a financial hardship, we should direct them to WIC where they can receive free formula and food for their entire family. So many of my providers and staff did not realize all the services that come with WIC. And I told them that our office cannot match the benefits that WIC distributes, and we should be actively encouraging families to take advantage of the state-provided social service that WIC provides. So with that, we created what I call the WIC card. So this is the actual card that we hand out to families if they're not connected with WIC. If they say to you, doctor, I'm having a tough time getting formula. Do you have any samples for me today? I say, I'm sorry, I don't have any samples, but here you can call WIC and they will help you. On the back of the card is the same information in Spanish. So we've written the baby's today's date, the baby's weight, and how long the baby is, because sometimes WIC will need that information. And we've trained one of the bilingual front desk staff at our office to help make these referrals. So this website, this is specific for Wake County, but this website is a really easy website where you can help the patient sign up. If you or your staff have a little extra time, you can help them sign up for WIC, and then they'll get a call within 24 hours to help get them what they need. And then lastly was breaking ties with the formula representative. So, one of my nurse managers said, well, what about the free lunches and the snacks that our staff love from the formula representatives? Well, we can do that, right? So what we've done is every quarter we have special lunches and we have a milkshake truck, and in the summer we had an ice cream truck come for our staff to replace the food that they were used to getting from the formula companies. And that's been a really great thing where we can take credit actually for providing that fun thing for our staff and that staff appreciation. And so we have seen a drastic decrease in the amount of formula that we have. We do purchase small amounts, and it is directed by our lactation consultant for those babies who need it for medical reasons. And so I would encourage you, if you're working in an office, if you are a lactation consultant in an office, maybe take some of these ideas to one of the providers who can help you champion it. All it takes is one person with the idea, and then talking it around and seeing who else says, hey, that's a really good idea. And then you latch on to that person and you go, let's fix this together. So the next thing we're going to talk about is monitoring breastfeeding rates in your office. I just want to spend a minute on this because when I was at Duke, my colleagues and I worked on Milkbox. And some of you have seen this and seen my colleague, Dr. Gabby Maradiaga, talk about how they created, and when I was at Duke, created a Milkbox within Epic, which is a way to track how the baby is feeding at every time when you see them. So you may not use Epic in your office, you may have a different system, but to have a way to routinely track how your baby is eating. In this case, they had nurses when they would room the babies, put them into the room, ask the mom and the dad, tell me, what has your baby been eating since you were last here? And they would just leave it open-ended. And then if the parent didn't know how to answer, they'd say, are they taking breast milk, formula, both, anything else? And so then they would be able to fill in this chart. And it gives you a really good way to sort of monitor it over the course of time. And then we want to talk about linking with breastfeeding community resources. Obviously, if you guys are involved with Breastfeed Durham, you are part of the answer with community resources, developing systems to guarantee continuity of skilled support for lactation between hospitals and healthcare settings in the community. Remember, it's not just about helping them when they're in the hospital and then waving bye-bye, see you later when they leave and hoping that they'll do great with breastfeeding. We need to continue that support in the community, which is why the work that Breastfeed Durham does is so important. I want to remind you about the North Carolina Breastfeeding Coalition resource map. So this is found on the NCBC website under resources. You can click into any of these regions. It's an interactive map. Click into the county specifically and find out where there are breastfeeding resources for your family. You'll see at the top right the change add listing blue button. If you have resources to offer in your community that are not on this list, please send us a note and add them to our list and we will get it updated. So this is constantly being updated thanks to lots of help from the North Carolina Breastfeeding Coalition folks. And then one of the last things we're going to talk about is normalizing breastfeeding. So I think we all do this in our everyday work. That video that Love showed at the beginning was so poignant and important. And you walk through that cartoon community and you see people breastfeeding on park benches. That's what we want. Here's an example of a campaign that I was involved with at my practice in California, where we printed life-size posters of women breastfeeding their babies. We used only staff and employees at the hospital. And so I happened to have a 9-month-old, Phoebe, who's now 8 years old, but she was 9 months at the time and I was happily breastfeeding her. And they said, do you want to be part of this campaign? And I said, you mean you're going to take my picture with me breastfeeding? No, I did not want to be a part of that. And they said, come on, it's really important. And I said, fine. So finally I gave in. And you know what? I'm so happy that I did, because this was a really important campaign. We had these posters all around the health center, all around the hospital, even outside on the benches outside the hospital were some poses of women sitting breastfeeding. And it was just so that you'd walk by and you'd think it was a real person breastfeeding until like you actually look closer and you're like, oh wait, that's a poster, that's not an actual person. They were very well done. On the right, you can see my middle daughter, Lauren, rubbing her baby's head. So I love that picture too. But I was really proud to be part of this. And actually now, 8 years later, they still pull out my poster every August for National Breastfeeding Month and station me near the laboratory in the hallway. And so my friends who still work at Kaiser Permanente will always go take pictures of them standing next to my poster and send them to me. So something simple like this you could do in your office. I want to share some other things that we do to normalize breastfeeding and to sort of be a congratulatory message to the parents. These next slides show ideas that Bonnie Reed, our lactation consultant, came up with single-handedly. She's so brilliant. We have these shirts printed that say 365 days filled with liquid gold, and then Western Wake Pediatrics. And we give the shirts out for any baby who is breastfeeding at 12 months old. Not just exclusive breastfeeding, but doing any breastfeeding at 12 months old, they get a shirt and mom gets a little sticker for her water bottle. Here we have these Drink Local Western Wake Pediatric sippy cups that we give at 6 months if the baby is breastfeeding at 6 months. And then a certificate of celebration that we give anytime we see a patient who has stopped breastfeeding since we saw them last time. And I just want to read this aloud. The certificate of celebration is awarded to, and we'll write the mom's name there, no matter how you did it, by nursing, pumping, hand expressing, breastfeeding, chest feeding, supplementing on your own with support, with help from a donor, for 1 day, 1 week, 1 month, 1 year, or maybe longer, you have given your baby a gift of a lifetime. We honor you for feeding your child with human milk and connection. We respect you for making decisions that are best for your family. We thank you for giving your baby exactly what they need. May your child forever be fed and nourished with love. So we give these certificates even if the baby got breast milk in the hospital and they come to us for their 2-day checkup and they're not receiving breast milk anymore. We give them the certificate because we think that's so important that they tried to breastfeed. And we wish that we could help. And sometimes we do actually, if they come to us at 2 days and they're not breastfeeding, we can get them back on track. But we celebrate that. And so, when I showed a while ago that gift bag from the formula company that you could get at your doctor, we've gotten rid of all that because we've supplemented with things like this, gifts from us that we can provide. And these are not that expensive, and patients love them. I can't tell you how many pictures we've gotten of 1-year-olds wearing the shirt that Bonnie will receive messages from our patients with the baby wearing the 365-day shirt. So patients love them. It's a really good way to sort of spread that normalization of breastfeeding. So shifting gears a little bit, I want to talk a little bit about lactation billing. So some of you may be wondering, like, how do I make this work in my office? I don't have a lactation consultant in my office. I don't even have anybody who really knows how to do it. Like, how do I make this work? So I want to draw your attention to the American Academy of Pediatrics Physician's Guide to Coding, which was updated in 2022. This is a 4-page document that has some good ideas. But I also want to tell you that this lactation billing thing is a work in progress. So I have been part of a national work group through the AAP to develop different CPT codes that we can use to bill for work done by IBCLCs on behalf of pediatricians or OBs in the office. And I say it's a work in progress because it's actually still going on. But last year at the AAP Leadership Conference, I helped to co-write a resolution. So every year, the AAP has a leadership conference where they hear resolutions from members throughout the US about things that they think the AAP should be working on for the next year. And so I wrote one with a couple of my colleagues from the section on breastfeeding and also the section on coding and office management to create ICD-10 and CPT reimbursable codes for infant feeding, so that the work that we do as pediatricians and the work that lactation consultants do on behalf of us and our patients can be reimbursed, so that we can pay for those services to be in our office, right? So that we can hire a lactation consultant, so that we can hire a nurse who has lactation training to help our patients, to give them more service than we can provide as providers in the 15 minutes that we're allotted to see them. And so this is important work that's still ongoing. And then lastly, I just wanted to end with celebrating breastfeeding support. So there are a number of awards through the North Carolina Breastfeeding Coalition that you can apply for if your office meets certain criteria. So the first of them is the Mother Baby Friendly Clinic Award, and we are in the process of revising this award, including revising the name to make it a little more inclusive. But I wanted to let you know about it because it's an award that you can apply for there anytime, and I'm actually in charge of it. So if you have any questions about it, I'm happy to answer those questions. But the two main hiccups that offices come up against when they want to apply for this award, but they realize they can't, is that the award requires you not to accept free formula. So we talked a bit about how you can stop doing that. And it requires that you have staff training of 3 hours for providers who interact directly with patients, including nurses, and 1 hour of breastfeeding specific training for all other staff, like front desk staff, for example. And so those are the two things that offices need to work on a little bit in order to apply for this award. But I would encourage you, if you're interested, to look at the criteria and reach out to me if you need help. These are the awardees throughout North Carolina. You'll notice that my office is not yet on this because it's something we are still working on. We had to get rid of free formula first. Now we're working on staff training. And so we hope to be able to apply for this award soon. There is also the Breastfeeding Friendly Employers and Community Partners Award. So my office does have this award where you as an employer can earn this award if you provide a breastfeeding friendly space for your employees, if you provide a private place for them to work, things we should all be doing anyways, but you can earn an award for this. So I would encourage you to check out the North Carolina Breastfeeding Coalition under the awards tab to see more information about both of these. And I'm happy to open the discussion up for questions or discussion. There's my email address there. And I just wanted to really thank Breastfeed Durham for all the really, really important work that you're doing. And I think this equity series is excellent. And thank you, Love, for all your leadership.
Thank you. There's a couple questions in the chat. Really start of a robust conversation about, Ann Fields asked, what about donated formula, like from the community? And Elizabeth shared that donated formula would be nice for moms who are going back to work, especially with WIC, because WIC provides monthly supplementation for formula, but most moms I serve end up with a shortage of formula. So I think that is an interesting conversation in contrast to what you were talking about the importance of a healthcare provider and the lens that healthcare providers role.
Yeah, so Elizabeth, I would encourage you to reach out to your local WIC department, because the parents who need formula should be getting all the formula that they need. If they're doing only formula, they should get that all from WIC and not just a supplemental allowance that allows them to fall short. So I would encourage you to talk to your WIC representative about that. And I'll tell you, the WIC people are so happy to talk to people about WIC and breastfeeding and infant feeding that they'd be happy to talk to you about that, to learn how we can better serve that community.
Okay, it seems that the formula is kind of expensive, so the amount of money that they get in those WIC vouchers are not, like, enough. That's what they tell me. So we can refer them to Welcome Baby and some other agencies that do give some donated milk, but they don't have it all the time. So we kind of have some donated gift cards to them. Sometimes we give them when they need it, like right now they don't have any. So we do that at my agency.
Yeah. And if you can do that, that's fine. I would encourage you to not have it be provided by the formula companies if you can. I mean, really, this is the role that WIC is set up to fill. And so if they're not filling it, we as providers need to push back on WIC and maybe help them fill the gap, but not fill the gap with free formula that's not coming from WIC.
I think I think we do have food issues here in Durham, and I think the Welcome Baby and our food pantries really are positioned and working to fill those nutritional gaps in our community. And we'd love to continue to partner with any of you as we could advocate and work with our WIC office. I think what I'm hearing is the critical role that healthcare providers play in normalizing breastfeeding, so that WIC and low-income parents could actually successfully breastfeed and get all the nutrition for their babies they need without that monthly expense. And Emily, if I'm correcting, I think the concern and the research shows that by the provider being the one that gives out the formula, that's making the parent feel like this is something they need, and it's actually increasing the use of formula.
Yes, that's right, Love. That's right. And I'm just seeing a couple things in the chat about WIC being supplemental, and you're right that WIC is supplemental, but again, that really speaks to working with the family and working with WIC to try and figure out how we can provide that resource for families that really financially need it. But without us, it's a hard balance without us giving it out to make the impression that we are promoting it.
We can promote breastfeeding as well. Like we have as long as they can, and if they have to start with formula, we can let them just do it overnight. So during the day, you can breastfeed, that's best for your baby and all of those things. And I even have a mom that she stay working from home so she can continue. Her baby is now 6 months and she wants to continue breastfeeding until she introduces regular milk, maybe 12 months or so. So, and it's really helpful to their budget as well, because they don't have to use, that money in formula. So
Yeah. And I love that idea of telling the mom like this, giving her a specific time, telling the family, giving them a specific time of when to use the formula, or, this is what we're going to do until you come back and see me next week. This is going to be the plan. You're going to breastfeed and then pump and then supplement with formula when you don't have express breast milk. And next week, we're going to come up with a new plan. This is not the plan forever.
Thanks for the presentation. That's great. And I love so many great ideas of things that offices can do. And I'm wondering if you have any recommendations of where's a good place to start, if you, both from your personal experience and also if there's anything in the literature about things that are kind of the most, I don't know, high yield, if an office wants to pick one thing to start with.
Yeah, so I think education would be the one thing to start with, staff and provider education. Even just a 1 month or a 1 hour lunchtime session during World Breastfeeding Week or something like that, where you're kind of just reminding people how important this work is and the benefits. And then I would encourage people to do is partner with somebody at your organization or your office. So this cannot be just a one-person thing, right? So find somebody who has an equal drive or a similar drive to helping with infant feeding and bounce ideas off of them. It really helps in my office to have a couple people who are really dedicated to this because it's really hard to move the ship as just one single person. But if you get a couple people on it, you can start to turn the tide. And I see a couple other comments about Anne started a program to make sure all parents get set up with a pump. Definitely, I love that idea. Pumps are provided through Medicaid, WIC, and through the Affordable Care Act, so making sure that patients know how to access that. And then Love asked if NCBC has resources for training, or is there a standard training module like for SLATCH, but for breastfeeding friendly offices? Sorry, did you want to say?
Another person asked that question and I was just responding that the Carolina Global Breastfeeding Institute has trainings, and Breastfeed Durham can always come out to offer trainings, and these trainings can qualify because thank you to CGBI, these are associated with credits.
That's right. And thank you for answering that.
And I just put the link to the Breastfeeding University in the chat.
And let's see, WIC provides mechanical pumps also, not just hand pumps, dependent on the baby's situation.
It's dependent on the baby's situation, and I've had a lot of difficulty with patients being able to get mechanical pumps from WIC, even when I've specifically called them and advocated for it. And all of the Medicaid managed plans now do provide pumps, which is great. That was not the case like a year ago. The Medicaid direct plan still does not cover a pump. They are working on it, is what I have most recently heard. So I think just like continuing to advocate for that, that really by law, they are supposed to be providing pumps to patients. I'm not really sure. I think that the way they get around it is by saying that WIC does. But then there's a lot of resistance from WIC to actually provide the pumps. And then a lot of time, like parents have to show that they are going to be working or they're going to be in school. Like, what is the reason that you would need a pump? And a lot of times, as we know, it can be beneficial to have a pump for many of ton of other reasons, and to go ahead and, be able to start pumping before that actually happens. So I think just another place that we can be impactful is to be advocating for everyone to have access to a mechanical pump. We try to get all of our patients set up before they actually deliver.
Yeah. So, Anne, if you have situations like that where you're having patients that you think should qualify for a mechanical pump, but they're not getting it through WIC, you can email me because I can help with that from the statewide perspective. We had a situation, I see a couple of my colleagues on here from Duke, where we were having a similar situation for my baby who was getting services at the Lincoln Health Center and was not able to access a pump, but then we were able to get it for them. So you can email me and I can try and help with those situations. Yeah. And Medicaid Direct, I'll look into that.
I think I'd like to say out loud, Emily, I was feeling like you're being thrown to the wolves here. I too am regularly hearing from parents. I think many of providers and assistants, peer-to-peer support providers are hearing that parents are not able to get the pumps they need from WIC. And we definitely continue to try to collaborate with WIC, but what we're hearing is the number of pumps that WIC receives is based upon the number of breastfeeding parents they had at the last data collection. And because we have really high health disparities here in Durham, we don't have established the breastfeeding numbers that we'd like to see. Oftentimes we don't, Durham WIC does not receive the number of pumps that it needs, but we've created kind of a self-feeding cycle where we just don't have the number of pumps we need here in Durham. And we would love your help advocating.
Yeah. Well, let me see. I don't know that I single-handedly can solve the problem, but let me see what I can rustle up and see if we can make some waves together. Yeah.
Yeah, I think that's the point here of what we're trying to do is make some waves together. We would love if you could give us another option.
And I just wanted to add on to like what Anne was saying about Medicaid not providing pumps and referring to WIC and the legality of that. I'm pretty sure that the Affordable Care Act did not, like those breastfeeding provisions did not apply to state Medicaid that did not participate in the expanded Medicaid programs, if that makes sense. So that's why they can get away with not providing a pump because North Carolina did not participate in the Medicaid expansion.
Yeah, I can definitely look into that more.
Well, we have 3 minutes left. So this has been a really phenomenal presentation and robust discussion. I think we've talked a lot about what pediatricians and healthcare providers can do, but also what we all can do collectively as community advocates around advocating for continued growth in our WIC, our nutrition services, our Medicaid. That is what Breastfeed Durham does all the time. I encourage you all to join our mailing list so that we can continue to make changes. And I want to thank Emily for joining us. We really, really appreciate it. And we appreciate all of the work you do as a provider, but also you all need to know Emily is an amazing advocate in her own right across the state of North Carolina and nationally. We want to particularly thank Breastfeeding Family Friendly Communities, our parent organization, the Carolina Global Breastfeeding Institute for paying so that you can all receive credits, and the generosity of the Durham County Health Department paying to make sure that these presentations happen. And I'm going to stop sharing and I'll put the link to the sign up in the chat as well.